Bismillahirrahmanirrahim. I'm Dr. Hala Shawki, starting MRCOG course, and today I will discuss a very important topic, maybe appearing in part 3 and in part 2. In part 3, it appeared in the form of dysmenorrhea in adolescents or heavy menstrual periods or ethical issue involving possible hysterectomy or request for hysterectomy from a mother for a girl with disability and at the same time adolescent. I will discuss today the most important points from the TOG article 2013, which can help in answering these kinds of questions. Let's start by information gathering and the assessment. And for that, we need to take the history of the present complaint, like the menstrual history, age of menarche, cycle regularity, duration of heavy periods, the flow, presence of loads, clots to assess the severity, the date of last menstrual period, and associated symptoms like intermenstrual bleeding or postcoital bleeding. Then the remaining will be sexual activity, the girl is sexually active or no. And we have to signpost by simple question only, some personal questions, and proceed, ask about if she's sexually active and if she's using, if there is issue of recent unprotected sexual intercourse, and ask about history of STIs. If the girl is under 16, safeguarding issues or lack of capacity, we have to assess safety. We call it safeguarding concerns. We have to ensure no evidence of coercion, abuse, or inappropriate age disparity in the relationship. So we can ask some kind of questions like, is this relation well known to your family and friends? Is the age difference between you and your boyfriend? Any issue of abuse, like presence of grooming gifts? Then the medical history, we have to assess for the UKMIC criteria for use of contraception. We have to rule out contraindications like presence of clot in the girl or her family, epilepsy, use of anti-epileptic medications, because we know that we have enzyme inducers which can affect the efficacy of the combined pills and POPs. Going to the social history, we have to check living situations, the support at home, school attendance, the impact of the condition on quality of life. And then the mental health assessment, if there is any mental health issue, lack of capacity, assess competency, GELIC competence. We ask the patient to repeat some of information given to her, and if she's able to retain and bring the information back and make use them to make decision, we will assess her like competent. And usually everyone is assumed to be competent until proved otherwise. Finally, the BMI is very important because the patient BMI affects the dose, affects the comorbidities, the clots. The investigations, full blood count to assess for anemia and iron deficiency, serum iron ferritin, pregnancy test if there is recent biopsy and no contraception or no compliance with the contraception, sexually transmitted infection screening if appropriate, and pelvic ultrasound only if there are clinical signs of structural pathology or severe symptoms. But the TOG article 2013 told us about the different options for adolescent and the girls lacking mental capacity. Let's start by the hormonal, including the combined contraceptive pills. They recommended the extended use, which could be greater than 21 days of active pills, of monophasic low-dose estrogen and progesterone pills. The aim is to produce fewer menstrual periods by doing the tricycling of combined pills, then giving only 7 days withdrawal bleeding every 3 months. This contributes to a treatment of the heavy menstrual bleeding in adolescents and lack of capacity. However, we have to put in mind the criteria for use. The first one will be the DVT risk, and if the girl is having some disability, making her sticking to wheelchair or immobile, this could be a risk. And the girls who have low BMI, the dose of pills could be overdose for them, which increase the risk of having DVT. So in these girls, usually we use lowest available dose of estrogen, and we will assess her for any personal or family history of DVT, which can increase the risk of having the impulse. And then the combined contraceptive pills will be contraindicated. Second concern will be the seizure disorders like epilepsy and use of anti-epileptic medications, including enzyme inducers like phenytoin and phenobarbital. Enzyme-inducing AEDs has different effects such as phenytoin and phenobarbital, which make estrogen metabolize more fast or faster, and so breakthrough bleeding will be increased, and we need to increase the dose of estrogen to control the bleeding. On the other hand, enzyme inhibiting AEDs like valproate and clonazepam cause COC to be more metabolized at a slower rate, and we have to use lower dose of estrogen. Combined pill can affect the AEDs and cause increase in the seizures. So we need to do dose adjustment. For example, in lamotrigine, its efficacy will be reduced by the estrogen, and so need to do dose adjustment for lamotrigine. In some girls, they cannot swallow the oral medications, and it could be not the best choice for them because this will affect the compliance. So until now, we have the combined oral contraceptives. We have the issue of it can help the bleeding, but it have the concern of DVT and seizure control and the effect on the anti-epileptic medications and the issue of the compliance. So depend upon the situation. Another concern here could be the another thing which can affect the choice, presence of dysmenorrhea, because COC are very effective in treatment of dysmenorrhea. Transdermal patch, which contains low-dose estrogen and progesterone, and therefore raise the same concerns like the combined oral contraceptive pills. It will be suitable if there is issue in the swallowing, and usually it will be changed weekly and with 1 week interruption for the withdrawal bleeding, but they can do the tricycle here as well by continuous putting the patches every week for 9 weeks and then allow 7 days for the withdrawal. If we compare to the combined pill, they found the breast discomfort, dysmenorrhea, nausea, and vomiting are more. So transdermal patch could be suitable option for contraception in the adolescents and lack of capacity. Coming to the third one, which is a progesterone-only pill, which are not recommended for the heavy menstrual bleeding because it takes long time, maybe 6 months for adequate menstrual control. The overall amenorrhea, 20%, 40% will have regular period and 40% will have erratic bleeding. And although the periods lighten and become less frequent over time, the bleeding may still be unpredictable, which may not be acceptable to some patients and carers. We know that progesterone-only pills contain low-dose progestogen, and some tablets depend upon changes in the cervical mucus. However, the newer POPs, which containing Cerazette 75 microgram, which is Cerazette, which contains 75 micrograms of desogestrel, work by inhibiting the ovulation as opposed to the thickening of the cervical mucus. This will give longer window period of for the missed pill, and has better side effect profile with fewer episodes of breakthrough bleeding, better control of the dysmenorrhea. So it could be an option for Cerazette, could be an option in case of dysmenorrhea, but it is not a good option for heavy bleeding. Coming to the medroxyprogesterone acetate or DIMBA, is not the first line in case of adolescent contraception because it will remove the issue of swallowing and the need for daily compliance and taken every 12 weeks like intramuscular injection. However, the main concern here is the effect on the bone mineral density in the adolescent. And we will have many authorities here discussing this, like the FDA. They mentioned here that all agreed it will lead to this reduction in the body mass, bone mineral density if used. FDA advised not to use more than 2 years, and we have to do baseline DEXA and scanning for the bone and continue monitoring annual, and giving adequate dietary supplementation, including vitamin D, calcium, and also concurrent use of low-dose estrogen. Another authority, they mentioned the same. The only different recommendation here is they advised that the duration of use need not to be restricted to 2 years if the patient is comfortable with using the DEMBA injection. The WHO mentioned no restriction should be placed on the use of DEMBA due to bone effect. So DEMBA still suitable, but it will not be the first line. And we have to put into account the effect on the bone mineral density and follow the guidelines by taking the baseline DEXA, annual monitoring for the bone mineral density, and giving good dietary supplementation and considering giving estrogen supplementation. And sometimes if it is suitable for the patient and appropriate, we can continue more than 2 years with the same precautions and discussion of the benefit and the risk with the patient or the patient carers if she's having some issue of mental incapacity. The second concern is with the DEMPA because it can increase body weight around 4 kilograms, so 4.6 kilograms per year. This can add to the risks of and quality of life and should be considered when we do the option. So finally, don't make it like the first choice. So until now, we found the COC is proper, the batches could be proper, and progesterone only pill proper for dysmenorrhea, but not for the heavy menstrual bleeding. And then the DIMBA will not be the first choice. Then coming to the nexplanon, and here they mentioned we have to be cautious in using. And we know it has low dose progesterone, subdermal, given for 3 years, and can induce amenorrhea in 20%, 50% will have infrequent period, and however, remaining will be irregularities in the period, and this is a main concern here. In addition, it can lead to irregular bleeding, and some will remove because of this reason, and the other main concern is severe mood swings, and the girls will be vulnerable or more exposed to the PMS. That's why it is strongly advised to be cautious when using the nexplanon in this group of population. GnRH analogs will lead to amenorrhea, and they test the GnRH analogs in the group of people with precocious puberty, children with precocious puberty, not in children with heavy menstrual bleeding or dysmenorrhea. And they found it will affect the bone mineral density, but reversible effect. It will recover completely when they stop. And but in the precocious puberty, they use temporarily until they reach the puberty, and then they stop. So, the effect could be different in the group of adolescent who need to take it for longer period in the critical age of bone development and growth. It can cause some side effects like hot flushes, headaches, night sweats. However, all could be managed by estrogen supplementation. Then the surgical options, and they can consider the LNG-IUS like a surgical option because usually they will need general anesthetic in order to put the IUS in this group of people. And it releases local hormone progesterone levonorgestrel 52 milligram. It releases around 14 microgram per day over a period of 5 years and could be used up to 5 years and lead to reduced blood loss and amenorrhea in 90% of population and also reduce dysmenorrhea. Obviously, it appears like very good option in our scenarios. And the cons, the only here main concern that we need to do it under general anesthetic and needs uterine cavity at least 5 cm size, and we have to do ultrasound before application, and this could be difficult without full bladder, and full bladder could be difficult in person who have lack of mental capacity. The other surgical intervention here, they discuss the endometrial ablation, which can lead to relief of the menorrhagia. And the pros, if we compare to hysterectomy, it has reduced the morbidity for people around 30s compared to 40s. And it will lead to reduce the morbidity. And the issue, it will need the people around the 30s will need endometrial ablation can lead to relief of both menorrhagia and metrorrhagia, improve quality of life, and compared to hysterectomy, there is a significantly reduced morbidity and save 40 or so years of hormonal management. The cons, the people around 30s will need further ablation more compared to the people around their 40s. The consequences in the adolescents are unknown, and if pregnancy happen, there will be complications like premature labor, and they usually need general anesthesia with its risk. And we can recommend the use of concomitant IUS in more difficult cases or for better control. Hysterectomy, this is an option, but here we have some ethical issue we'll discuss, and we have a question detailed about that in part 3. I think also it will be like part or potential for many questions which can come in part 2. And here we do only for the benefit of the patient, not for the caregivers. So the first choice will be the medical treatment, and the surgical will be the last option, and under exceptional circumstances only. We have some ethical consideration. We have the Mental Capacity Act, um, and which state that incompetent adults should be treated in a way that serves their best interests. And they state that we have to consult range of people when determining the best interest of a person who lacks capacity. This act doesn't cover the children under 16. Under 16, usually children are not always capable of participation in their own treatment, and that's why we have to involve the parents in making decision. But we have to some rules. We have Children Act and Family Law, and the GLIC-Fraser guidelines, which should be followed. And we have 2 points here are relevant. The first one, requirement for the intervention should be the least restrictive for the basic rights and freedom of the girl. The second, those with parental responsibility have the legal right to give consent on behalf of the minor for medical treatment. But this decision or consent shouldn't be allowed to come to serious harm because the parent refused consent for appropriate treatment or insist on a treatment the doctor believes it is not the best interest of the girl. So the interest of the child must be paramount. And the surgical options will be the last resort when symptoms and signs of menstruation are severe and the medical management have failed and not for the benefit of the caregiver. Under UK law, approval from a high court judge is necessary before surgery can be carried out. One of examples of this ethical issue when a mother come and request a hysterectomy for a girl because she lacks of mental capacity, and here we have to explain to her it is not about her. We will respect her wish. However, we will explain to her the legal issue and that it should be the best interest of the girl. We will take her wish into account. However, it's something needs to be decided by the high court judge. And we have to assess the competency of the girl, and her wish also should be taken into account. And then we can give her alternative options like Mirena, which could be one of the larks and can give efficacy on heavy menstrual bleeding without major surgical intervention. And then at the end, we can go for this hysterectomy if the surgical option, if the other options have failed with the treatment of the heavy period with the girl. So these are the most important points which can help you in the choice and in answering these types of very important questions in part 3. To summarize, the suitable management option for a 15 years old girl who have heavy menstrual bleeding could be: first, correction of any anemia by iron supplementation. The hormonal management, we will give her the options with the pros and the cons. So usually we start by the LARCs, LNGIUS, and COC could be an option. Oral progestogens could be used to stop the bleeding if no issue of contraception. And regarding the other options which not suitable will be the DEMPA injection. It is not first line, but it could be considered if other options are not suitable, because we have concern about the bone mineral density, weight gain, and menstrual irregularities. Progesterone only pill is not recommended to control the bleeding because it takes long time to control and associated with much menstrual irregularities. And the nexaplanon, because it should be used with caution because it can lead to effect on the adolescent, including mood swings, PMS, and menstrual irregularities, which is a reason for discontinuation in many of the users. And we have also the non-hormonal management methods, which should be offered, like tranexamic acid and non-steroidal anti-inflammatory with no contraindication, like bronchial asthma. We have to give the girl follow-up plan and ongoing care. Adolescent could be assessed by specialists, teenager gynecology or sexual health clinic. And we have to monitor the effectiveness and the adherence to the treatment.